Welcome. My name is Ellen Levine. I work for an organization called Cancer Support Community Central New Jersey. We are physically based up in Somerset County in a town called Bedminster. And there is an office of our organization in Eatontown as well, in Monmouth County. You guys are kind of midway between the two. It's a national organization that provides free support and educational programs to people affected by cancer. And there's literature out on the table outside that you can pick up. Looks like this. It's a brochure, and like this, which is a calendar of programs. And that's one of the reasons I made sure to get your contact information so you'll receive information about future programs. Our organization has had a long collaborative relationship with the Regional Cancer Care Associates and a more recent collaborative relationship with the East Brunswick Public Library. So we have been working together to provide educational programs, rotating with the different doctors from Regional Cancer Care Associates on a variety of topics. And so you can expect to hear about another program that will be held in the spring. I don't know what the topic will be. But please spread the word. And if you find the program helpful, you can tell people that they will be able to see it. It's being videotaped, so they'll be able to see it, I guess, through the East Brunswick Library's website and probably through the RCCA website, and it'll be put on there as well. So it's a way for us to reach more people than those who are physically able to get here tonight. So again, welcome. I want to now introduce our speaker, who many of you know already. Ellen Ronnen is one of the medical oncologists with Regional Cancer Care Associates Central New Jersey. Okay? So, and tonight's topic, as you all know, has to do with breast cancer and specifically an update. So, welcome, Dr. Ronnen.
Thank you for coming. I'm hoping to teach everyone something tonight about breast cancer that they didn't already know. I was joking with some of you before. I don't love public speaking, but I do love talking to my patients. And the reason why I love talking to my patients is because I think it's a tremendous opportunity to educate our patients and teach them and have them be their advocates. And so, although I was thinking, oh my gosh, I have to give one of these talks and I get so nervous, I thought to myself, think of this as trying to help a larger group of people. It's a patient who brought 15 family members. So, the topic of the talk is updates in breast cancer in 2017. But before I will talk to you about some of the new findings and some of the updates of what we're doing, but I wanted to give you all an overview just to make sure that we all have the same basic understanding. And so there are 250,000, it should be women diagnosed in the US each year, 2,500 cases in men. Obviously breast cancer can afflict men. And when we think of treatment for breast cancer, it can be surgery, radiation, and then we call it systemic therapy, meaning the body is a system and you can give either chemotherapy, hormonal therapy, and there are newer classes of drugs that are also becoming more mainstream for breast cancer. And depending on the stage of disease you have, you might get one of these, two of these, or all aspects of this care. And what I talk to my patients when I see them is that depending on your stage of disease and what treatment plan we're constructing, we will either monitor you when you're done with active therapy, or we will continue to monitor you if you remain on therapy. But monitoring is a really important part of taking care of breast cancer patients, and I try to make sure that every patient knows that. Even if you're, quote, just on hormonal therapy, you do need to see your doctor intermittently. These drugs have a long list of side effects. Some of them you can see, some of them you can't see, and it is important to remain in good contact with them. And so, and as I said, I'm going to talk to you about how we're changing our treatment options to try and cure more and more patients. So I thought I would start with who gets cancer. It's obviously more common in women. Increasing age is important. And you'll see with the increasing age and the postmenopausal weight gain or just obesity in general and early menarche and late menopause, a lot of these are centered around estrogen exposure. And this was also talked about years ago with hormone replacement therapy and the fact that there is probably a slightly increased link to breast cancer. So as you advance in your age, as a woman increases in age, she's had more and more years of having estrogen in her body. And estrogen exists in fat tissue, which is why obesity is a risk. If you go through menses early, you have more years of estrogen exposure. So a lot of those are related to the same risk. Dense breast tissue is a risk factor for breast cancer. It's not one of the strongest risk factors, but it is. Dense breast tissue causes two issues. One is it sometimes becomes more difficult to screen patients with our mammograms, but it also separately, there is an increased incidence of breast cancer in women with dense breast tissue. And then alcohol and cigarettes are also linked to an increased risk of breast cancer. Family history is something which any of you who have ever been in the office with an oncologist, we often spend a large part of the first visit talking about that, just trying to understand what your family history is. And that's because the world of genetics and breast cancer is changing rapidly, probably as rapidly, maybe even more rapidly than the medical side of it. And I was saying to someone right before we started that when I first joined the group in 2006 and someone had criteria to meet, someone met criteria for genetic testing and I tested them, we only tested them for a few genes. And I've continued to follow these patients and I see them now and the patients, it's 11 years later, and I've asked them if we could retest them because there's so much more that we know. There are 21 gene assays, 20 gene assays. So family history is something that we do focus a lot on, although I will talk about how you know who requires genetic testing. And this isn't an exact science, but insurance companies have definitely had their opinions about who should be tested and who shouldn't, but there are standard criteria which we can go over. So the only thing I was saying on this slide, just as a general introduction to the topic, is that if you have a first-degree relative who had cancer regardless of the age, the approximate designation is that there's a 2-time risk. Your risk is twice that of the general population. That number is a little bit skewed by how old the affected family member is. So if you have a father or a mother who had, or a mother who had breast cancer at 85, your risk is probably going to be less than 2 times that of the general population. But if your mother had breast cancer at 34, that's definitely going to probably make your risk higher than 2 times. So although we do spend a lot of time on getting family histories and trying to make sure that we don't miss the opportunity to counsel a patient and potentially other affected family members, hereditary breast cancer is only accounting for 5 to 10% of all patients with breast cancer. And this slide also says that BRCA1 and 2 can explain 25 to 50% of the hereditary cancer cases. So those are the most common genes that we know of right now. But the other section on this circle graph, the familial, so to me, and I think to all of us, what this really means is that there are genes that we don't know of yet. So sometimes I meet a patient who says to me, this person had breast cancer, this patient had breast cancer, this patient had ovarian cancer, and the history seems very suggestive to me of a familial syndrome of some sort, including breast cancer. And we send the entire panel and it all comes back negative. And what the literature says with the test results that you're supposed to give the patient, but also educate the physician, is they say that although basically right now they haven't identified the gene, is it possible that down the road they might? And so we do say to those patients that a family history, even if you're genetically negative, does increase your risk, and we want those patients to be monitored more closely. So going back to the basics of breast cancer before we get into some of the interesting new areas for breast cancer in the last year or two. So staging, I just put this up here just because I wanted to make sure everyone understood the basics. And there are 4 stages of breast cancer that's invasive. Stage 0 is pre-invasive, which generally means that if you can believe your pathology report and it's ductal carcinoma in situ, that you should have no risk of long-term distant disease recurrence. You should not have the ability to have metastatic disease based on the biology of that because it's in situ, it's above the basement membrane of the tumor. So that's stage 0. And then stage 1 and 2 and 3 and 4 are, the increasing stages of breast cancer with more disease, and you can see there how patients tend to do with those in terms of long-term survival. But the treatment for each of those is different based on your stage of disease. And I'm also going to go over what also will kind of change your treatment, which is your hormone receptor status and your HER2 status. So we'll go over all of that. And it's just as another figure showing that, obviously patients with early stage disease will do very well, and then we're still more challenged with getting patients with more advanced stage to do well, although a lot of the drugs that are coming out are targeting metastatic patients and are slowly moving the needle in the right direction, although not as fast as we would like. So this is just what I was saying, just to continue to give you an overview so that we can have a better discussion. So the breast cancer subtypes, when you look at the breast cancer cell, the estrogen and progesterone receptor are considered hormone receptors, so HR. And then the other one that is commonly discussed and very important, central to the treatment for breast cancer, is the HER2. So there are 4 basic types of breast cancer based on those 2 areas. The most common breast cancer, and you can see on this slide, it says 73% of all breast cancer is hormone receptor positive and HER2 negative. And so that is, by far the most of what we see. And the treatments that are becoming available are often specific for a subtype. Either they're for triple negative, which is the final group on the right on the bottom, or they're for hormone receptor positive, or they're for HER2 positive. So they are very specific, which kind of gives you a little window into the idea that we're increasingly trying to find targeted therapy, which is very different from where they were years ago, where they just kind of gave chemotherapy and hoped that any rapidly dividing cell would be killed by it. Now they're trying to figure out what drives this woman's breast cancer versus this woman's breast cancer, and let's give her a targeted therapy. So we will talk more about that. The next thing I wanted to talk to you about, given that the most common subtype is the hormone receptor positive and the HER2 negative, is the potential that we would overtreat patients. And this isn't a new update in 2017, but this is, I think, one of the biggest things that's happened in breast cancer in the last 10 to 12 years. And it's changed even in my short time in this field. So if you think about the patients with hormone receptor positive disease and HER2 negative disease, what it means to have the hormone receptor on your surface is that you can manipulate that to trick it and to kill breast cancer cells. And it gives you kind of a hook or target into the cell. So you want them to have the hormone receptor on the cell because it's an opportunity to get in and to give them the signal that you want. This is the most common form of breast cancer. So the question has been, if you have an early stage breast cancer patient, say a 1 centimeter tumor, which is considered a small tumor with no lymph nodes involved, and the tumor is hormone receptor positive, do you need to do more than give her an anti-hormonal therapy? And what would the more be? I'm talking about a systemic treatment. I'm not talking about radiation. The more would be chemotherapy. So given that this was the most common type of breast cancer and the majority of patients were early stage, many researchers were looking at this in the early 2000s. And I have seen this change in my lifetime. What I mean by that is when I was training in fellowship, we were taught that if you saw a patient with early stage breast cancer, if the tumor were greater than 1 centimeter, which is an arbitrary number, I mean, let's be honest, you should probably offer them chemotherapy. As I was finishing my training, researchers in California came out with a test called the Oncotype. And this isn't a new test, but I just wanted to go over what it does because it really changed how many, many hundreds of thousands of women were treated. What this test said was, we're going to look at 16 test genes. Well, actually, they looked at hundreds of genes in a tumor bank of a large group of women who had hormone receptor positive tumors. And they were trying to figure out what genes predict a risk of recurrence. They stopped saying, we're just going to look at the size of the tumor, we're just going to look at the grade of the tumor. They said, let's really try to get at the biology of the tumor. Because if a woman neglected a breast cancer, and the tumor was a very slow-growing tumor, but she didn't go to the doctor for a year or two. When she gets to the doctor, it still might be a very favorable tumor, except it was just larger because of the time it took for her to get there. If you just based it on size, you might give her chemotherapy, which is, first of all, unlikely to work because the tumor is slow growing and not actively dividing, but two, can cause her a lot of side effects. So what they did is they created a recurrence risk assay. They went through many genes. They found 16 tester genes and 5 control genes. And now what you do, and this is standard of care, when you have a woman who has node-negative disease with a hormone receptor positive tumor, in other words, you know you're going to give her hormones at some point, and your question is, do I need to give her more? You send the tumor, not the blood. You send the patient's tumor to the lab in California, and they will give you a recurrence risk. And the recurrence risk will help you decide if the woman needs chemotherapy. And if it's a low risk score, which is 18 or less, they not only will tell you that chemotherapy is unlikely to help the patient because the patient is so favorable, but they'll also give you a likelihood that the woman, if she takes hormones, anti-hormones, an anti-hormonal therapy for 5 years, what her potential risk is at 5 years, or actually at 10 years. And so they divided it into low risk, high risk, and intermediate risk. This is still an area of active investigation because we use this test, it's FDA approved, there's not an issue with that. We do not know what to do with the intermediate risk patients. And so the low risk patients are recommended not to have chemotherapy. So many women that I was standing there when my mentors in fellowship gave chemotherapy, those women would not have gotten chemotherapy today. The high risk patients are recommended chemotherapy. The intermediate risk patients, they're not sure. And so the recommendation, if you look at some of the standard guidelines that oncologists use, will say have a extensive discussion with the patient and talk about the risks and benefits specific to them and their medical problems. There is a study looking at this right now. So this is what's happening in 2017, but we do not expect that data for a number of years. In that study, they gave women who are intermediate risk anti-hormonal therapy in one arm, and in the other arm, they gave them anti-hormonal therapy and chemotherapy. And so this is just a little bit of a background on this because I think this has changed the landscape of how we treat early stage hormone receptor positive breast cancer. And one side note on this is that, do we use this for everyone? The patient population that was studied in the original article, in the original study, a postmenopausal population. So it's, in general, the very young population we do not apply this data to. But even though it's been studied primarily in menopausal women, we would feel more comfortable using it for someone, say, in their 40s, but in their 30s and in their 20s, we generally don't use this because the data has not been validated. And this is just a schematic just to show you an illustration of how things have changed. And this isn't complete, but this just shows you, and even with this, and I'll talk about it on the next slide, there's more going on. So you can see it hasn't been that long that we had tamoxifen. And then the aromatase inhibitors, which are the newer class of hormonal therapy, were only approved in 1999, or actually 2002. So it hasn't been that many years. And they're also trying to, in the advanced breast cancer population, add to them both for hormonal therapy and the anti-HER2 therapies. I'll only talk a little bit about, but there's a lot on that as well. And then the triple negative population, there are multiple regimens that they found are more successful in that population. And so this is a constantly changing field, building on what they knew before. And so this just shows you the cell, but I wanted to bring this slide up because you can see what I was talking about with targeted therapy. It's not just, we're just going to try to eradicate cells that are rapidly dividing. HER2 is on the surface, so obviously some of those drugs are working, trastuzumab and pertuzumab, which isn't on the slide. But they're also looking for other parts of the mechanism for how cells duplicate. And so it's a rapidly changing world. And to show you how rapidly changing it is, this slide is from this year. And you can see on the bottom it says CDK4, CDK6 inhibitors, palbociclib, and there are two more which are on the next slide, which are now, one of them is approved for upfront and the other one is on its way to that. So I'll talk to you more about that. And here's the slide I was talking to you about. So this is just to show you just this year. And so if you say that this is Arimidex, Aromacin, Femara, many of those were in the last 15 years. The Aromacin and Afinitor combination, which was on the slide before, is more recent. Femara and Ibrance is with the CDK4/6 inhibitors. And just in the last few months, two more in that class, the ribociclib and the abemaciclib, have been approved. And there's just a lot changing right now. And those are for the hormonal therapy. And I didn't, just in the interest of time, talk to you about the chemotherapy that's being added and the HER2-based therapy. I apologize, it's coming off the slide a little bit. So the HER2-based therapy, I just wanted to spend a moment on this slide, just because it shows you how they're also changing how they determine how to study effective regimens. So one of the problems with giving chemotherapy to an early stage breast cancer patient is that it's a problem for the researchers, but it's great for the patients, which is that most patients won't recur. And if they do recur, it might not be for a very long time. So the advanced breast cancer patient tends to be the population which many drugs have initially been approved in, because you can say, okay, well, this is their metastatic disease, let's give this drug and see if it shrinks their tumor, which you can watch in real time on imaging. The other way that they've increasingly been looking at in the last 15 years is giving chemotherapy to women before their surgery. And this is specific for this is done more commonly for HER2-based therapies. But there's an interest in looking at, if you give the chemotherapy to women who have their breast cancer in before you take them to surgery, and then you send them to the surgeon, you can get an understanding of what is the percentage of women with a specific regimen that have no cancer at the time of their surgery. And that has been predictive in terms of how patients will do. So to give chemotherapy before surgery is called neoadjuvant. And so this study that I was just showing on the right of this slide, Herceptin is the oldest of the HER2 targeted therapies, and then a drug called pertuzumab came out, which is also known as Perjeta. So the study on the right was giving trastuzumab and docetaxel in the pink, pertuzumab and docetaxel, so it's comparing the two HER2 therapies, trastuzumab and pertuzumab without chemotherapy in the light blue, and then the royal blue is both HER2-based therapies with docetaxel. And I just wanted to show how looking at the response after chemotherapy at the surgery can predict how patients might do. So what these numbers are is the percentage of women at the time of surgery who had no cancer in the specimen. So pertuzumab has only been with us for a few years. So almost 50% of women had no cancer at the time of their lumpectomy or mastectomy, compared to the regimens that were standard just before that. So that's another way that we can try to get answers more quickly for patients and know what are effective drugs, and to try to move those therapies forward a little bit more quickly, because patients really need therapies more urgently than we're able to provide them. So to move on a little bit to some symptoms, but before I do, does anyone have any questions right now about anything we've talked about so far? Just, yes?
So you had mentioned, a lot of these therapies are coming out very quickly. Does the fast track, clinical FDA, whatever it is, help? I mean, are there any disadvantages to having these drugs fast track, or the risks involved?
So the fast track has definitely helped drugs become available more quickly. I think there are two concerns with that. One of them is related to any drug that's immediately FDA approved, and the other is related to the fast tracking. When drugs are fast tracked, the question is, what endpoints are they using? And when more data comes out, will those endpoints stand up because they're being fast tracked? But the other issue that potentially could affect patients with any drug that's been recently approved, fast track or not, but fast track means even fewer patients might have been exposed to it, is that the side effect profile might change as you get more data. And so in general, I think we as oncologists think it's helped patients to get drugs more quickly and not have them delayed in approval. But I think that's always been a concern of ours with the side effects, is that you have fewer patients who've had the drug. So will it be well tolerated, which is the expression we sometimes use. Other questions about some of the general overview? Okay. So just to tell you a little bit more, just thinking about things that have changed this year, and we're kind of running the gamut. We're doing a little bit of therapy-based changes. I'm going to talk a little bit about symptom management now, and then I'll go into a little bit of genetics. So symptom management. So hair loss is obviously a very distressing thing for women undergoing cytotoxic chemotherapy, and this has been talked about for many years. And so they have been studying this, and this picture is an illustration of, two women with cold caps on, and there are generally two systems that they use. One is that they are constantly having cold material circled to the scalp, and the other is that you have a cold cap and then you replace it as it warms up. So speaking about cold caps and scalp cooling systems, the concept behind it is that if you cool the hair follicle, it'll be less susceptible to hair loss. And this has been studied most commonly in the drug Taxol, or the taxanes, I should say, in breast cancer. And it actually, the multiple studies have shown that about 50 to 60% of women will retain their hair if they use these cold caps. Obviously, I feel almost silly for writing the problem as headaches and cold, but it is true. And I've talked to just a few patients who have used this, and it can be, especially since many of my young female patients are cold in general, even before they get chemotherapy, it can be very distressing to be sitting getting chemotherapy. And we currently don't have this in our office, but we've been looking into it. And so this was approved in the last year and a half, and it's something that I think many oncology offices are trying to provide to their patients. So this is just something in terms of another way that they're trying to help with symptoms. Along those lines, women and men who are treated for breast cancer and other diseases where they get some of these drugs can get neuropathy, and it can be very painful, and it can start very insidiously. It can, and anyone who's ever talked to one of us in the office, you'll know that every time we see you, we're asking, the treatment nurses are asking, are you having any numbness, any tingling? Are you having any heavy feet? Because the symptoms can be vague. Someone can tell you their balance is off, and just subtly, or their feet feel heavy, they notice it walking upstairs. So neuropathy can be very disabling to people, and because we use the taxanes a lot in breast cancer, we see neuropathy in breast cancer patients. And so the only thing I was going to say about this cold therapy for neuropathy is that the data has not been proven yet. I have had multiple patients who've actually asked me if they could bring in coolers to the office and do this during their treatment to try and prevent it. And we, as a group, we do not have an issue with anyone doing this, but it's important to note that the data has not yet consistently proven a benefit in reducing neuropathy. So they're studying it, but the data is not consistent. There are some studies that report a benefit, and I think sometimes patients will see that and assume that it's a guarantee. It's not. I don't think this is as distressing to my patients as putting a cold cap on necessarily. I think this is why a few of my patients have done this in the office. So I wanted to switch gears now and talk a little bit about genetics. And so this was an article published this year in the late winter, and it talked about the percentage of women who should be candidates for genetic testing, but it had not been offered to them, or if it was offered, it either wasn't covered or they ultimately didn't get it done. And so this is a very active area of discussion and investigation in oncology. And we're trying very hard to make sure that we don't miss the opportunity to genetically test patients if they're appropriate candidates for it. Some patients aren't appropriate candidates for it, and I'll go over that in terms of the general guidelines of who you should be testing and who you shouldn't be. But I wanted to just make sure that we mention this because it's a really important issue. And it's not that common anymore that in breast cancer, someone wouldn't discuss it with you because the family history is almost always asked. But I've occasionally seen patients with breast cancer who were treated many years ago and were diagnosed at a very young age, and they weren't tested. So it's always, and you might say, well, why would you test that patient now? They were treated 20 years ago, 35, and now, and the obvious reason is because if you found something, it would affect her, the woman sitting in front of you, because she might be at risk for another cancer, which you could do preventive testing for to prevent it or find it when it's early. But it also can affect people in that person's family. And so you can affect a larger and larger spectrum of patients. So it's still appropriate to get an appropriate history, even in a woman or man who's been treated many years ago, because the testing wasn't available and they probably didn't have it. So talking about the genetics of breast cancer, and I focused a little bit on BRCA because as you saw before, that's the majority of women who have genetic abnormalities, they are BRCA positive. So the BRCA prevalence is 1 in 400 to 800 women in the United States, but the risk is 1 in 40 in Ashkenazi Jews. And the risk of the primary breast cancer. So why do we care about this? So BRCA1 is approximately 60% risk of having breast cancer by the age of 70. BRCA2, slightly 45% chance of breast cancer by age 70. But there's also the risk of the second primary breast cancer, and there's also the risk of the other cancers. Specifically with BRCA, you might worry more about ovarian, which that's why it's called the hereditary breast ovarian cancer syndrome. But you also might worry about pancreas and even prostate. Those are the most commonly reported for the BRCA patients. And so depending on what gene abnormality you find, it might predict or it might determine what you're going to do and how you're going to monitor them. So who needs BRCA? This is a very busy slide, but I wanted to show this because this is one of the most commonly asked questions that I get. And so I'll read some of the more important categories. So obviously if an individual has a family where there's a known BRCA1 or 2 mutation, that patient should get testing. So that would be applicable to the family of someone that you find the deleterious mutation in. And so we will say to a patient, if we find it, all of your first-degree relatives should be tested, which would be your siblings, your children, your parents. And so even though those people don't have cancer, aren't our patients, we always would say to them, make sure you tell them they should go wherever they live to someone and talk about genetic testing. So talking about cancer patients, if you have breast cancer, regardless of what subtype you have, if you're less than 45 years of age, you should be tested for the BRCA genes. And actually, the panel is broadening. And when you're very young with breast cancer, even without a strong family history, it's generally approved to do a more comprehensive breast cancer panel, a high-risk cancer panel. And so 45 years of age, regardless of what type you have. And then if you're less than 50 and you have even one close relative. But then, just to show you that it even allows you to get tested later on, if you have a triple-negative breast cancer and you're less than 60, you should get genetic testing, at least for BRCA, possibly for more. The other question I often get, and this has changed since I was in training 15 years ago, is if you have someone in front of you who is of Ashkenazi Jewish descent and they have a breast cancer, regardless of their age, regardless of their type, triple negative, ER, PR, HER2, they should be tested. And so that's not always been on this. This page is actually from the National Comprehensive Cancer Network, but that indication is newer in the last few years. And as you go through it, and I know it's hard to see, but they also talk about if you have a strong family history of ovarian, or if you have a family history of prostate, pancreas, or ovarian. Having ovarian cancer by itself, regardless of having ovarian cancer regardless of anything else, your age or anything, you should get genetically tested for BRCA1 and BRCA2. So these are just some of the reasons why we would genetically test. And this is not complete, and there's a lot more genes, but I wanted to go over this with you because it's probably one of the most common questions that I get. So then talking about prevention. So what can you as a person do who doesn't have breast cancer and you're trying to be healthy? So we don't know exactly why breast cancer happens, so it's hard sometimes to prevent it. What has been proven though in large studies is that regular physical exercise will provide modest protection. So I wrote down, and that benefit is highest in postmenopausal women. I wrote down what they consider regular physical exercise because that's often a question I get, and it's 30 minutes 5 times a week, which can be brisk walking, but that has been shown. Now the reason why that might be related to this is probably related to what I was talking about when we started, which is the fact that obesity is a risk factor. So in general, if you're exercising more, you might be less likely to be obese, and that might play into that. A Mediterranean diet with more fruits and vegetables has been again shown to potentially provide modest protection. And then I wanted to put something down because I also get this question, which is soy, and in Western women there's been no association with an increased risk of breast cancer because of that. And that goes back and forth. They have a study that shows it, they have a study that doesn't, but there's no definitive link. And so if a patient who has breast cancer says to me, what should I eat? How should I change my diet? I basically say to them that you want to be as healthy as possible, meaning you want to have everything in moderation, you do want to try to be active, and you want to try to get to your goal weight. But when we get too specific and we say, well, should I take all of X out of my diet? That hasn't been proven. The entire lifestyle change has been proven, and that's exercise, getting to your goal weight. So I was going to stop there, and I can open it up to questions. Yes?
I attended a luncheon this afternoon at Steeplechase, and your third one, soy, they said avoid it.
So the question was, or the comment was, that she was at an earlier educational session in the day, and they said to avoid soy. So I think this is a perfect example of how you can find articles that say to take it and articles to say not to, but if you look on the standard guidelines of what is generally recommended from, I won't say the National Comprehensive Cancer Network because they don't talk so much about prevention, but similar organizations, they cannot find a definitive, persistent link.
Are you with the Cancer Institute at all? Are you affiliated at all?
No.
Cancer Institute?
No, we're completely separate. But the Steeplechase, if you were at Steeplechase, the oncologist at Steeplechase is part of the Regional Cancer Care Associates.
That's why I asked, and they were very definitive today.
Yeah, no. So,
Soy out of your vitamins.
yeah, no, that it's, you can look, and there's, so they can say that you can find data saying it's for and it's for against, and and the standard recommendation is that you cannot come down hard on it. I mean, if you listen to them and you say, well, why would I take the risk? I'm convinced that the data that's against it is going to become the definitive data in the field. By all means, don't do it. But I want to be honest about it, that the data hasn't definitively shown that from study to study to study. And this is similar to other areas which I didn't talk about, which is the bisphosphonates, which we give to women for, and the bisphosphonates, which are a class of drugs which are given for osteoporosis. There have been multiple studies over the years, which many of you might know about whether or not that can prevent a recurrence in breast cancer. And it seems to me, going to the national meetings, that every year the alternating view is presented. And so in 2017, the It Doesn't Help was presented in one of the European countries, although I don't remember which. So take that for what you will, but that's really where soy is, and it's similar in some ways. Hi.
So, the BRCA gene thing, so we talked about this. My mother is BRCA negative, and she's got triple negative breast cancer. And so I've been told that since she's negative, I don't have to be tested for the BRCA gene. And everybody is leaving it at that in my family, but I don't feel comfortable. My insurance won't pay for the test. People are saying, why test if your mother is negative? And you test, we've had her tested. And so why bother going further? But people are saying that my father could be BRCA positive as well. I mean, that's highly unlikely, but I'm very, I want to take care of myself now, being my mom's here to tell me what she is and what she's not,
Right.
you know?
So, yes, yes,
Yes.
yes, I will. I was planning on repeating them all. So, but you can remind me if I don't. So her question is that she is the daughter of someone who was tested because of a cancer history, and that patient had a comprehensive panel that was negative. And so her question is, can I believe that? Should I, who don't have cancer, be tested because I am an Ashkenazi Jew, although, and my mom did have cancer, although she was genetically negative? Is that so this is,
Yeah, and the insurance is saying, if you want to test yourself on your own, you can.
right.
You can.
So what's important to remember with all of these is that you really need to try and understand when you're sitting with a patient as much as you can about their family history. I'm going to actually try to go. So when you're sitting with the patient, you want to understand their family history, and you want to know who in their family had something and what that patient had. The problem is that they want to test for the person who is alive with the cancer, because that's the person who's manifested the disease. So this actually raises, so a similar question, and then I'll continue on yours, is if the person who's alive who has the cancer doesn't have a family history, that actually often just qualifies them, but doesn't disqualify, that's enough to qualify them. But the difference between that and what you're asking is that they have had cancer. So the insurance companies aren't willing to test someone who doesn't have cancer if they've done a comprehensive testing on the person who had the cancer. And so I do understand why that is. I think that, and we mentioned this before, but I'll bring it up again, having a family history of breast cancer, even if you don't find a gene, does increase a woman's risk. But unless there's a really strong family history of many other things, they won't pay for it because it doesn't make sense to them because they have tested who does have the disease.
Right.
Now, you bring up an interesting point, though. So if a person has, but this actually goes back to what I said. So if a young woman has a breast cancer and she's tested and she's positive, and her mother had breast cancer, and her mother's tested and she's negative, you should test that patient's father. Because where did she get it from? And her mom's cancer might have been sporadic. So when you were saying test your father, it would be very relevant if you not only had cancer, but had a genetic mutation, because you would wonder where it came from. But for you to test your father when you yourself haven't had cancer, they will not do that testing. Does that make sense? I mean, this is a really active area of discussion and interest.
But the fact that I am BRCA negative and all
Yes.
the genetic testing came out negative, does that mean my daughters won't get it?
So you did not pass down a gene to them. There are other, and this is what I was saying before, there are so many genes that they've tested for. And so it might be, and I would sincerely hope not, but it might be that one of your children could develop breast cancer and have a different gene that either you weren't tested for, or, well, it would have to be that you weren't tested for since you were tested for so many.
But you did a whole panel on me.
Yes,
And
yes.
they all came back negative.
Yes.
So what
Yeah, but I'm sorry, we have to
Right, and that's what I was saying. That's why it's so important that when you sit, and especially when there are sometimes language barriers with patients, that's why it's so important that you make sure in the appropriate language for whatever patient that they understand that you're not just asking for the kind of cancer that they have. Because, you know, and that's why, and that's actually why in the Medicare program that they're overhauling a lot of cancer care in this country with, one of the mandates is that you have translator services available to all your patients. For one of these reasons, is you need to make sure in their own language they understand you weren't just asking is there breast cancer in the family, but for example, was there pancreas in the generation before you, was there prostate? And there are other cancers which I'm not mentioning that are also linked to BRCA. And of course, there are other syndromes that I'm not even talking about that, you know, like a lot of the colon cancer syndromes that have a lot of other different cancers. So you want the whole history. They call it a pedigree. Yes?
Have you gotten the pricing of the testing? It's not expensive. I had, for various reasons, I had testing done. I didn't have a first-degree relative that I knew about that had cancer. My wife figured out. So when my cousin's got cancer, she figured out she should probably get tested. And the insurance company wouldn't cover it. Now, the whole genome was $2,000, but because of the BRCA, it's only right. It's
Yes.
only one gene, and that was like $200 or $300. You're not talking big money anymore.
Right.
That was like 3 years ago. Today we'd be talking about a couple $100 to do it.
So you think it's relevant, it's.
If it's something that I think,
I was positive. It turned
So-
out positive, but the
so-
insurance company wouldn't pay. But all I had to do was test for one gene, which is only a couple $100.
so his comment was that you have to understand what you're asking when you ask how much it costs, because you can pay for comprehensive genetic testing, but especially in the Ashkenazi Jewish population, you really are looking for the most common BRCA mutations, which has been quoted to us and quoted to you. Our numbers are very similar as a few $100s. So he was commenting that if you know you're Ashkenazi Jewish and you really just want the most common BRCA mutations tested, it can be much less than the 2,000 or 3,000 that the companies are telling you it will cost. And that's a great point.
Okay, so you just sifted out
Well, you tell them you want to test. You speak to the doctor, but you just want the specific Ashkenazi gene, a specific gene.
All right,
rather
I'll
than
talk to you
the
later.
whole-
Yeah, thank you,
Okay.
thank you.
Other questions? Yes.
Do you see research being geared mainly to younger women maybe in the future? I know a lot of resources is for menopausal women, but how about the younger generation?
They are doing, I hope I didn't lead you to think they're not actively studying the younger population. While the younger population is smaller because the average age of breast cancer. So the question is, I apologize. The question is there research going on for the younger breast cancer population? And there is, and breast cancer, because it is so common, one of the benefits of it being so common is that it is easier for researchers to be able to get studies done with a high enough number of patients that it will actually mean something, because it's not hard to accrue to these studies. So there are people looking at young patients, and a lot of the area of young patients, for example, when I said that the Oncotype DX testing with young patients isn't generally done, that's because it was, that's been looked at, and it's generally not, it's not thought to be necessarily as reliable, and early stage young women with breast cancer can have a higher recurrence risk. We know that because we've studied those women. And so that's why, so that study specifically was targeting young women. The other areas that are looking at young women is, and this is geared towards hormone receptor positive patients, is when I was saying in the illustration of where they've done advances in breast cancer patients who have advanced to breast cancer, and they were talking about the aromatase inhibitors, which are the newer drugs that came after tamoxifen. Those drugs are targeted for postmenopausal women, but they've been shown to help more than tamoxifen. And so they have studied in the very young population that they think also might have a higher risk of recurrence. Can they give those women ovarian suppression and those medications in comparison to tamoxifen? There were 2 large studies that were devoted to that topic. So they are looking, and I don't mean to inaccurately represent, there is a lot of work going on for the young population because often they can have more aggressive breast cancer, and also they obviously have the most years that they could lose if you're not successful in taking care of the disease. So it's a good question. Other questions? You're a quiet group. Did I answer everyone's questions? So, okay. Well, thank you very much for coming. Feel free to come up to me and ask me questions.